Okay, so thank you everyone for joining this webinar today. We are going to be discussing approaches to providing inclusive adolescent sexual health referrals, and we will have some awesome speakers here with us today. My name is Bria Pringle Weston. I am a current adolescent sexual health intern with NCSD, and I will be moderating for you today. Okay, so quick disclaimer, this is a development and this presentation of this webinar was supported by a cooperative agreement with the Centers for Disease Control. The opinions, findings, and conclusions do not necessarily represent the views or official position of the U.S. Department of Health and Human Services or the Centers for Disease Control and Prevention. So reminders, we look forward to hearing your questions during our interactive Q&A session at the end. During the session, we will ask that attendees stay muted. To ask a question at any point during the webinar, please use the Q&A tool located in your Zoom control bar. If you would like to add your comments through the chat function, please select the All Panelists and Attendees before sending your message so that everyone can see it. We will also have closed captions for this webinar. So to turn it on, click the CC or closed captioning button on the Zoom control bar. And if you have any other questions or need any other assistance, please comment it so that we can help you out. And then also, same thing, this webinar is being recorded, so the presentation slides will be emailed to all of those who registered, so don't worry, you won't miss a thing. And for our objectives for today, so by the end of this presentation, you will learn strategies and best practices around making equitable, inclusive, and relevant referrals for young people. You will also be able to understand key principles for providing inclusive, affirming, and supportive care for youth. You'll recognize and understand the intersecting identities and systems of oppression that impact Black individuals' experiences with sexual health. These things include race, gender, sexuality, class, ability, and so much more in order to provide holistic and inclusive care. We will also be discussing gaps in sexual reproductive health. So we have a lot of objectives today, but you will learn a lot from our speakers. So I want to definitely get started with our presenters because that's what we're here for and that's what's important today. I'm not going to give their bios just yet, but just a brief overview. We have Quatisha, who is the founder of Questions with Q, and we also have Claudia here today. So I'm going to go ahead and get started. Claudia will be starting our presentation today. So before she begins, I am going to give her a brief bio. And just quickly before that, I want to give a little bit of background about the referral toolkit, which is really why we're here today. This webinar is a part of our series, and I want to give a brief background that inspired this series. So the Referral Systems Toolkit, this toolkit is designed to support education agencies develop a comprehensive referral system and associated protocols, resources, and tools that will effectively increase student access and connection to key youth-friendly and LGBTQIA+ affirming sexual health, mental health, and supportive services. If you would like to access the toolkit, you can scan this QR code. We will also have this QR code available at the end, and it will be sent out in the following slides following this webinar. So to begin, I'm going to go ahead and stop sharing my slides so that Claudia can share her slides. And I'm going to go ahead and just give that brief introduction while she's doing that. So Dr. Claudia Douglas is an adolescent medicine physician and researcher at the University of Washington and Seattle Children's Hospital. She is originally from North Carolina, which is where she received her medical degree. She then completed a residency in internal medicine and pediatrics at the University of Colorado. She moved to Seattle in 2020 to complete an adolescent medicine fellowship and an NIH T32 research fellowship. Her research and clinical interests include Addressing Sexual and Reproductive Health Disparities for Adolescents and Young Adults. She is particularly interested in improving access to care for youth and is utilizing mixed methods and implementation science to identify and improve gaps in care and education among youth and parents in the Seattle area. Passing it off to you.
Thank you so much, Bria. Thank you, Christy. Thank you for the NCSD for having me and for everyone who joined. So I will be pretty brief, but I wanted to talk a little bit about engaging adolescents and families in sexual health care and education, and a little bit about the work that I am doing. And I have no disclosures today. And so my objectives are really to be able to identify where youth are receiving sexual and reproductive healthcare and education, also to understand that a one-size-fits-all approach often when we're talking about Black youth with regards to sexual and reproductive health, it often excludes marginalized adolescents. And then also to discuss the importance of parental involvement and how much or how little it should be involved in topics around sexual health education and care. So I am briefly going to talk about the data. You all probably honestly know even more than I do at this point, but as kind of a refresher, we know that youth, particularly youth aged 15 to 24, account for almost 50% of the new 26 million STIs that are diagnosed each year. And we know that there are significant disparities and inequities in STI rates. Over the past 5 years, rates of chlamydia, gonorrhea, HIV, and syphilis have been highest, particularly among Black youth, but also among other youth of color. And specifically with regards to Black youth, have higher chlamydia rates, 10 times higher gonorrhea rates, 13 higher rates of HIV diagnosis, 7 times higher rates of syphilis than white youth. And we also know that this is not because of the behaviors of Black youth as much as it is because of the structural inequities that frame access to care. So we know that while these rates are continuing to increase and the disparities seem to be getting even larger, on the other side of that, the public funding is also going away and being cut. And so now more than ever, it feels like there's this need to understand how to efficiently and kind of pragmatically provide this type of care and education, particularly for Black and other marginalized youth. So a little of my talk is going to highlight some of the research that I'm currently doing or attempting to do with this ultimate goal of trying to increase access and education to all youth, but really for Black youth. And so for me, I guess this question of how to efficiently deliver sexual and reproductive care and education begin with the question of where are youth actually going for this care currently? So I'm from North Carolina. I moved to Seattle in 2020 for my adolescent fellowship. And I knew that Seattle wasn't going to be the most diverse place in the world, but I was confused because I would see a lot of Black teens in the community at sporting events, in the grocery store, around, but I weren't seeing them in my clinical settings. And when I did see them, especially for Black young girls, I would see them for symptoms of an STI, but not the screening for an STI, or I would see them for the pregnancy test, but not the contraception. And so it feels like I was always seeing teens too late when I even was seeing them. So this kind of started my quest for wanting to know the settings in which youth primarily were receiving sexual health and how that varied by race, if it even varied by race. So I started by looking at the IBM Market Scan, which is a large secondary database. And I used this database to see where youth with Medicaid insurance had a chlamydia or gonorrhea test done in 2019. And this was done nationally, but across 10 to 12 unidentified states. And the results ultimately of this study were that over 400,000 tests had been performed among youth, gonorrhea and chlamydia tests. And that 49% of the tests occurred among white youth, 37% occurred among Black youth, 37% among Hispanic youth. So some of the results were surprising, some of the results were not surprising. So as an example, medical offices were the most common, the most prevalent testing location among all youth, regardless of race and ethnicity, at about 38%. Not super surprising, although probably could be higher. But the data also did highlight some, I guess, areas of concern or areas that were maybe a little more surprising. So in particular, this data highlighted that overall 20% of youth are using the emergency departments for their gonorrhea and chlamydia tests. And we know all the reasons why that's not good. We know that undertreatment, overtreatment, being lost to follow up. We know that there are documented racial biases in emergency departments, especially with regards to sexual STI testing. And so all of these things kind of piqued my interest, but I also recognize that this is a Medicaid data set, and so there are a lot of limitations. One of the other things that I thought was particularly interesting with this data, though, is that among the other locations in which I grouped the last 10 most prevalent places, school-based health systems were a part of that at 1.5% prevalence. And again, I understand that Medicaid data sets have their problems. Not all students have Medicaid, but it did kind of pique my curiosity to want to understand more with regards to where kids are going. So I did a similar study where I live in King County, which is where Seattle is, but using public health data of cases. And so I looked at chlamydia, gonorrhea, syphilis cases in 2019 among 15 to 24-year-olds. And honestly, really similar to the Medicaid study, it was about 30% of cases that were diagnosed in primary care offices, but also very similar, about 15% of the cases were diagnosed in emergency departments or urgent care settings. And similar to the other study, only 2% were diagnosed in school-based health clinics, which seems very, very small. And although I haven't separated this data out by race yet, I think it's logical because of the disparities that we see in STIs, even in a place like Seattle, to think that the numbers for Black youth in King County are also going to mirror what I saw in the Medicaid data set with Black people disproportionately receiving care in urgent cares and emergency departments. So as a, I guess, early career faculty sciences, I'm trying to figure out how do I design or create something that's going to meet Black youth where they are? And what does that even mean to meet Black youth where they are? And so I super appreciate the NCSD for creating this wonderful toolkit. But I think what the data that I just shared kind of shows is that we may not always be able to start the algorithms for referrals and toolkits at the schools or at primary care offices. So maybe meeting kids where they are, particularly for Black kids, mean that we need to extend the algorithm to have different branches that maybe start in emergency departments or urgent cares that kind of help bridge community navigators or school-based health centers or something to get these kids even into the places that we start our referral systems. I think it's also important that when we talk about only 30% or so of youth utilizing primary care or medical offices, and that number was lowest among Black kids as well, that there's a lot of studies that show the ways in which particularly pediatricians don't do a great job of having conversations around sexual and reproductive health. And if this is the only place that kids are going, but providers, particularly pediatricians, don't know how to talk or how to prescribe things like PrEP or doxyprep, then particularly for Black youth or really for all youth, then are we really meeting youth where they are? So I'm going to shift for a second to kind of talk about school-based health centers. I feel like so often they're a part of decision trees or referral services, and they should be. They're super important. They provide primary care, dental care, mental health services. They are usually in places that serve underserved youth. However, as the data in both the Medicaid and in my county data shows that we are probably super underutilizing school-based health services for things like contraception and sexual health. Some studies show that less than 50% of school-based health centers are actually able to provide contraception. And while we know that this is likely dependent on the location and the laws and logistics of certain places and school districts, it's also very dependent on provider knowledge and youth knowledge, just based on my own clinical experience. So if a provider can't do things like IUDs in a school-based health center, then that's a service that a kid is missing. Also, if we're not able to do the most basic things of providing contraception, again, it's very likely that we're not able to do things like offer PrEP to kids where this may be our only opportunity to reach them. So again, just wanted to use this to kind of reiterate that while we're building these policies and interventions and referral services, that there is really no kind of one-size-fits-all approach. So as an example, we're building something or a model in California may not be the same as what a model may look like in North Carolina, but also based on my own experiences, building a model at a school-based health center in Seattle may not look the same as another school-based health center in Seattle. So making sure that we're approaching all of this with the kind of wide eyes and the ability to always improve. So I wanted to highlight this data that initially wanted to look at how school-based health centers could help eliminate disparities and better serve adolescents. So this data was taken from the 2011 to 19 wave of the National Survey of Family Growth, and basically it looked at sexual activity and receipt among those who identified as females, 15 and 19 years old, and were either Black, white, or Hispanic. And so what you can see is that more than a quarter, 26% of high school females who had had sex in the past 12 months had not received any sexual or reproductive health services, and only 34% had received an STI test. The same study, when broken down by race, shows disparities in sexual and reproductive health services. So in particular, Black female high school students were significantly less likely, 9%, than Hispanic females at 27%, and marginally less than white females to have received emergency contraception or emergency contraception counseling. And although it's not a significant difference from a statistical standpoint, you can see that still only 34% of these girls received STI testing. And when you think about the disparities that exist among like Black and Hispanic girls, these numbers they should not be the same. They're already low, but they definitely should not be the same. So again, just kind of highlighting areas that we can improve upon and models that we already have. So not having to build something new, but trying to improve what we already have. So what about sexual health education? Most of what I've discussed thus far has been around sexual reproductive care, where kids are getting care, what does that look like where kids get care, but what about the sexual health education part of it, particularly for Black youth and youth from other marginalized groups? So how do we kind of meet them where we are, not only for sexual and reproductive care, but also for education? So the CDC defines what a quality sexual education program should look like. And so it's really straightforward. They should be taught by well-qualified and highly trained teachers and staff. They should be inclusive, in particularly with regards to people of color, also with individuals that identify LGBTQIA communities. They should also connect students to other resources, both in the school and in the community. And lastly, they should engage parents and families and community partners in school programs. However, what we actually find is that young people are actually getting less sex ed now than they did 25 years ago, so 1994. So this number is also taken from that National Survey of Family Growth among 15 and 19-year-olds from 2015 and 19. And specifically what the study highlighted was only about 50% of youth reported receiving sex education that meets the minimum standards that were set by Healthy People 2030, which is what a lot of these referral systems are based off of. And out of that, only 45% of youth received this instruction before they had sex for the first time. Also, way more teens reported receiving information on abstinence-only education than about where to get birth control or even how to use a condom. So again, areas in which we can improve. So like most things, there are also disparities in sexual health education. So that same survey showed that non-Hispanic Black males, Hispanic males were less likely than non-Hispanic white males to report having received instruction on a range of topics before they ever had sex. So things like prevention of STIs, methods of birth control, where to get birth control. Also, 30% of non-Hispanic Black females reported that they learned where to get birth control before having sex for the first time, compared to 45% of non-Hispanic white females and 49% of Hispanic females. So why is this important? Again, if we're not reaching Black youth with simple topics such as contraception or where to get contraception, then we know we're not reaching Black kids with more advanced topics, again, things like PrEP. So where are Black youth receiving sexual education? We know that they're receiving, for the most part, something in schools, community settings, religious setting, media, peers, parents. And yes, religious settings, while depending on where people are from, seems crazy. There are lots of studies that show, particularly for Black youth, that religious settings are the top one, two, or three places where they receive their sexual education. However, those studies also show that when kids receive sexual education in religious centers, they're more likely to be told about abstinence, and they're less likely to be told about things like STIs and HIV. But really, for the purposes of this talk, I want to focus on the parents. So I included this graphic because I always find it interesting. It's from the Pew Research Center. They surveyed over 3,800 parents, and it shows that among Democratic parents, Black parents were more likely to say that schools should teach abstinence than other groups. And it's interesting because as an adolescent medicine physician, I think that we kind of have perceptions and stereotypes of people and parents, even within my own community. And I think that we have done a really good job of protecting confidentiality for adolescents. I also think, mostly because of a lot of political talking points right now, that many parents feel like they've kind of lost autonomy over their child's health. And not saying that it's right that they have it, but it does feel like we could do a better job of preparing and talking with parents about what this autonomy looks like for their kids' sexual and reproductive health. Um, Black people are not a monolith, and while this applies to, you know, Democratic parents saying that they would prefer abstinence more than other groups, that doesn't mean that all Black parents feel this way. And so I also think it's important to have conversations. Usually, when I'm talking to parents, and even when they have these beliefs, very simple conversations with parents usually changes their thinking. So I try when having these conversations, instead of going right in and talking about the HIV testing, I try to focus also on like the healthy relationships part, consensual sex, and what that looks like, especially knowing that 1 in 4 Black females are going to experience sexual assault before they even go to college. So those are the conversations that I'm really trying to have and frame with my families. So, one of the things that I'm trying to do to get a better understanding and potentially develop interventions that help parents with this and help parents be able to better transition their kids to this stage of their life, this stage of their healthcare, is to conduct a qualitative interview. So, I live in Seattle, and Washington State have very progressive politics, but small numbers of Black people. And it can feel some days like pulling teeth to try to get the community engaged, to get their community to trust healthcare workers for a variety of different structural reasons. But even in these very progressive cities, when we look at rates of STIs, we still see significant disparities that exist among Black youth, particularly Black women. And so a lot of times, even though I live in Seattle, a typical day in my clinic when I'm seeing Black kids feels no different than when I was in med school in rural North Carolina seeing Black kids. And it's interesting. I've had a friend recently tell me that she did this girls' trip with some of her friends, and that the conversation around all these people who are super educated, doctors, lawyers, judges, were that we don't really feel comfortable in having conversations around sex with our teens, but we also don't feel comfortable having other people have these conversations. So my goal is to try to get a better understanding of ways that I can help engage parents around sexual health. So conducting these interviews via snowball sampling, and very new in the process, and only conducted some interviews thus far, but it's been super interesting to see how Black parents in Seattle have responded. So one of the questions that I ask is about religiosity, and I would say while about 50% of the parents state that they're religious, pretty much none of them actually go to church here in Seattle, which is completely different than if I was asking this question in North Carolina. Another interesting part of this study is that while I asked about whether kids are receiving routine care and that all these kids have a primary care provider, none of the parents referenced primary care providers as the ideal place where their kid would receive sexual education or care except as a last resort. The parents do, however, kind of express that school-based health centers are the ideal place where they think their child should receive not just sexual and reproductive care and education or care, but also education, although these parents also are largely reporting that they don't know if their schools even have school-based health centers, and if they have them, they haven't done any like marketing towards the parents to let them know about the services they provide. One of the last points that the parents are kind of all express is this need for community. They all state that when it comes to feeling educated themselves about how to talk about these topics, that they would prefer to have community, people who look like them, people who also have teens, that they want to have these conversations in group settings where they can bounce ideas off each other, share information with each other, And they all expressed that they wouldn't feel embarrassed or they wouldn't feel ashamed to ask questions, but instead they would feel more empowered because other people are going to be asking the same kind of questions. So, takeaways of all of this: consider gaps in care education as we're building these models. Consider that they often miss Black and other marginalized youth. Go into communities and recognize that there's not this like one size fits all approach, and have conversations about what these teens, what these parents, what these communities are actually needing. And then lastly, ensure that the interventions and the policies that are being built are actually helping the people that they're intending to reach. I think it oftentimes feels like towards Black parents that interventions for sexual and reproductive health are kind of bypassing Black youth, that there's this push now, like for all sexual and reproductive health services to go towards kids that are kids that are gender diverse or MSM. And I think what I'm hearing from parents is that it often feels like public health doesn't really care about Black kids anymore, particularly Black girls anymore. I cannot imagine what it's like to have to be at the top making decisions regarding how these resources are allocated, but I am begging you to please don't forget this population of youth while we're building these referral services, while we're coming up and creating these interventions, but to continue to push for policies and interventions that are going to improve the disparities that exist among these kids. But thank you so much for listening, and I will stop sharing my screen and pass it to Q.
Thank you so much, Dr. Claudia. We really do appreciate it. We are going to move on to Quatisha. So I'm going to go ahead and share the slides. And then I will read the bio. Give me 1 second. Here we go. Everybody can see? Perfect. Okay, let me read the brief bio. So Quatisha Bailey is the founder of Questions with Q LLC, an independent health promotion and wellness consulting business designed to strengthen young people and adults throughout the state of Colorado. She has worked in the public health field for 14 years and in the clinic for 5 years, supporting comprehensive sexual health and prevention education, and has facilitated presentations to adolescents, young adults, and parents throughout the state of Colorado. She continues to support her communities by collaborating with healthcare systems, judicial systems, schools, and community-based organizations. Passing it off to you, Q. If you have any questions, anybody who is watching, please feel free to drop them in the chat box or in the Q&A.
Thank you, Bria, for the wonderful introduction. Thank you, Christy, for this opportunity, and NCSD for being able to be here today. Good afternoon, everyone who is attending this webinar. Next slide, please. So welcome to Referral Linkage to Healthcare and Black Youth. I wanted to give you a little more of a personal bit of who I am. I am a Black woman from Stockton, California, born and raised. I grew up around violence, drugs, gangs, teen pregnancy, all of those high-risk behaviors that you can name. I've seen it, been there or done that. And I'm just so grateful for my coach slash mentor who saw something in me when I was this young 16-year-old girl who tried out to play basketball. I actually had a scholarship to play here in Colorado at a Division II school. So that is why I have landed here in Colorado. I have, like Bria said, 14 years in the public health and prevention field. I've earned 3 degrees. I've worked with well over 10,000 students, whether that was in the judicial system, whether it was with healthcare or clinics, whether it was around diverse communities, athletics, college campuses, just a lot of students and youth that I've reached throughout my career. I started my own consulting business in 2023. Around this time, so I'm just about starting my going into my second year. I've secured about $75,000 in funding. And I've worked in the healthcare or the clinical setting for over 8 years throughout my career. Next slide. So questions with Q, Bria had already shared with you that I am a collective. I'm here to really strengthen our youth, and I provide health and wellness education and provide resources to youth. Before I talk about specifically working with the Black youth, I wanted to kind of give you a little snippet of the things that Q's with Q is doing currently as a whole with all youth. So partnerships and connections, I really wanted to talk about that. I also wanted to share with you the impact that Q's with Q is bringing with schools, nonprofit organizations, and also state funding and health department collaborations. And I also want to share with you the magic sauce, which is the anonymous text line, which I'll share with you. And then I'll get into my connection and my work with youth. Next slide, please. So partnership, I am currently the project director of a CDPHE comprehensive sex ed grant, which allows me to go into the classrooms. And so I'm connected with a wide range of healthcare and clinics. And so I have a lot of relationships with healthcare services. So I'm able to tap in, and I'm integrated into two school districts that, and also a charter school. And these schools are located throughout the Denver metro area. And so because I am connected with healthcare services and clinics, I'm able to tap into reaching out with communicating with other services that provide reproductive health or family planning, birth control, and things like that. I'm able to connect with them and send students directly to those to get those services. And so partnership, collaboration, all of these just come together when working with schools and making sure that the trust is built. So in my previous work a few years ago at Children's Hospital, I was a part of the Adolescent Medicine family planning clinic, where I was embedded in all of the high schools in Aurora Public Schools district. So when I decided to branch out and start my own independent consulting business, I just connected or reconnected with those partners, those principals, those community liaisons, also those students back then that are now staff members, and that trust was already there. So when the funding opportunity became available, I reached out to those contacts and said, hey, there's funding that'll allow me to come back and facilitate some of those health and wellness education presentations. Next slide. So I want to talk about the impact. And like Claudia said, excuse me, meeting teens where they are. It is so important to meet teens where they are. I found myself putting together all of these presentations to facilitate to teens or youth. And I realized that that's not what it's all about. They actually like when I sit on a desk and have conversations with them. I also bring a trivia question spinny wheel that has different topics on there. And that's what we tend to talk about. In the grant, we are allowed to pick a curricula. So I made sure to host focus groups with students throughout the schools that I am implementing program in, to be able to find out the need, the culture, and what curricula will actually fit those students in each school. I'm actually running two different curriculas in other two different school districts in two different schools because the audience is just so different. I try to provide a safe space, but I also say that I like to provide a safe and brave space for students or youth. The content, it changes all of the time. I want to make sure that the content is inclusive and it's engaging, and it's making sure that I'm asking questions and covering various topics like anatomy, healthy relationships, consent. Those trivia questions kind of jump in and tie into some of those presentations. We talk about STIs, HIV, birth control methods, or hormonal methods, I should say. And then I provide them with resources and referrals too, because I want to make sure that all this information that I am giving them, I want them to know that if they are sexually active or are thinking about being sexually active, that here are resources that provide free and confidential or low cost services for youth. And then I also share with them, when you're going into the clinic or when you're calling to schedule an appointment, here's how you advocate for yourself. Instead of saying, I don't know what to say, sometimes they do say that. And so I make sure to go over how to advocate for yourself, what questions to ask, and also be specific in what your need is and ways to get a quicker appointment. For an example, you know, if you've been exposed to an STI, you need to be seen to get tested. Um, you call and you ask to schedule an appointment and let them know that someone had shared with you that you may have an STI, and that appointment will be, you know, kicked up a few notches to get you in right away. Next slide. So the magic sauce to all of this work, it's really the anonymous text line. So what is the anonymous text line? It's a 24/7 anonymous text line where teens can text any questions that they may have. I'll show you a few text messages in my next slide, but no question is off limits. It's medically accurate information. I am a health educator at heart, but I don't, some questions are way above my pay grade. So I make sure to reach out to my doctor friends, is what I like to call them, or my providers that are doing the work in the clinics. Hey, how do I answer this question? Or how would you respond to this question? And most of the time it's, hey, make sure that they schedule an appointment to get in. And so I also have a team of health educators that are skilled and inclusive with the LGBTQ questions that may come up. You know, things change, language change. I wasn't aware of what the word T was, and that meant testosterone. And so I didn't shy away of not knowing what it really meant. So I asked. And so how often is, or I'll say, why is this text line so successful? Because it's right there at their fingertips and they're not being judged. It's a clean slate. When I am answering questions, I try my best to make sure that race is not included. Age is, because there are laws surrounded around the text line. And also at the age of 12, you're allowed to be in control of your own reproductive parts here in Colorado. And so I make sure that the text line is accessible. I get, it's not an overwhelming need, or excuse me, it's not an overwhelming text line to manage, because as soon as their questions is met or answered, or as soon as they are referred to a clinic or a healthcare service, they don't have any more questions. But the good thing about this text line, which is the next slide, please, is I have teens who are still, well, they're no longer teens anymore. I have teens who are still texting this excuse me, text line 4 years later after this anonymous text line has been created. And the good thing about this text line as well is being connected to those family planning clinics, being connected to the health departments that are offering free and confidential services or low cost services, being connected to those youth sexual health clinics. And the question that I ask teens when they are texting, what community or what area do you live in, so I can tap into those connections with healthcare clinics and services that are close to them, because we know that transportation is a huge barrier for teens. I'm gonna just, for time's sake, I'm gonna just jump right into the last question. I have a question. I got an injection for treatment for gonorrhea at the clinic, and I noticed a bump by my genitals, and I was wondering if that would go away after the shot. These are just a few of the questions that I get. Yes, they do talk about mental health, all different types of topics that I cover. And I'm just available, and I'm excited, and I'm happy to be able to provide these services and be able to link them to resources to help them. Do you remember being a teenager and having questions around your sexuality or being sexually active or whatever the case? I think that this text line or having something like this would have really helped us out. But I just wanted to acknowledge it and allow you all to see some of the questions that I do come across. Next slide. So my connection or my experience connecting with youth. First of all, I am a Black woman. I had shared that earlier. I grew up as a young, youthful teenager in the 90s, and I grew up in poverty. And I tend to share those stories and those experiences so I can build rapport with our Black youth. I make sure that it's judge-free and confidential. Um, and like I said, I share those personal stories because I feel that some of the things that our Black youth are going through, I want them to know that what they're going through today doesn't dictate what their future is going to be. And to look at me. And I also allow them to share their stories and share their experiences as well. And when I am providing resources and connecting them to healthcare services, it's a trusting service or a trusting resource that I am connected to, that I actually go on my text and text providers and healthcare providers in settings to say, hey, do you have time, or how's your schedule to have a couple come in for STI testing today? Is that something that you could do? So that's where that inclusive referral system kind of comes into play. And then it's a warm handoff. Next slide. I wanted to make sure that I cover creating engaging experiences. I am so sorry, excuse me. There are a lot of programs throughout the Denver metro area that are provided for our Black and Brown youth. YMOP is Young Men of Purpose, which is a young and it's for youth in a school setting. They meet once a week at a few schools that I'm also integrated in. I have a partnership with YMOP, and it's a men's group that allows that is designed to teach Black and Brown high school boys around social emotional wellness, conflict resolution, cultural identity, social justice, and equality. And then Q's with Q hosted our first Remarkable Young Women's Conference, which is an annual event. We had over 70 participants, volunteers. We hosted this event at a high school to give them that high school feel. We honored remarkable Black women doing work in the community. And we also covered topics as healthy relationships, mental health. How do we take care of you? How do we inspire our young Black girls? And this was specifically for high school age girls between the 11th and 12th grade. I'm now partnered with the Lady Blackhawks Youth organization, which is for young basketball players. And we have created and started an Empower Her 2 workshops, which is a 6 weeks health and wellness workshop teamed up with a youth licensed therapist that co-facilitate these workshops for the next 6 weeks. And we've started that a couple weeks ago. And coming soon, just hosting monthly workshops for young Black girls, maybe pizza and paint, to get some conversations going, career development, financial literacy, and just going back to having a mentor or a coach that can be able to kind of shift and guide some of those experiences with our Black youth. Next slide. So I know I'm over time. I want to be, I'm going to slide through these real quick. Challenges, parents. We know, as Claudia said, parents could be a challenge if they feel like they're not in the know. Racism in the healthcare system, it still lives, and it's still a thing. And I think that if we can sometimes, as providers or community health workers, whoever we are, to know, to check those biases that we may tend to have, or those implicit biases that we may tend to have, because we are historically, we know, with all of the things that had happened in the past, that some of that is still going on. And asking those trivia questions in a clinical setting, I wish that they would be a little different. But growing up, we were told as a Black girl that we don't share our business and we don't talk about our business. And so at times when you ask questions in a clinical setting, it could trigger something. The language, terminology, slang, it changes all the time. So it doesn't hurt to ask, to give. I make sure that I'm giving medically accurate information and the words that we are using, penis and vagina, and then also ask them, what do you call it? What is your slang words or your language around? And then sustainability. I would love to have apply or search for sustainability and funding to be able to reach those homeless youth, the youth that are in foster care, and the ones that are in group homes. Next slide. Opportunities, parents, again, there's always collaboration or coming or listening to parents and what they have to say. There's always opportunities for that. Partnership with Black folks. Don't be afraid to ask questions in regards to or giving compliments, building rapport. All of those things are just very important. I try my best to create innovative ways to connect with youth in general, but I think that at times we can, I know it's hard to say, but what I try to do with the text line is I just make sure that I hear the problem or the issue, and then I'm connecting them and linking them to those services to get help. And so I want us all to think of that in that way when we are serving our Black youth, especially after what Claudia had shared with us with all the data. Next slide. Thank you very much. I apologize for going over, but I'll pass it back to you, Bria.
Thank you so much, Q, for your presentation. We are going to move directly into our Q&A session. So we will have maybe a little under 10 minutes for our questions. And if we don't get to any questions, don't worry, we will be providing them in our follow-up. So let's go ahead and just jump right into it and get started. So I'm gonna try to start with the targeted questions that were specific. So we have one for you, Q, that says, what advice would you give school systems that are interested in partnering with Black-owned CBOs and practices that serve inclusive referrals to sexual health services?
Sorry, can you repeat the question again?
No problem. What advice would you give school systems that are interested in partnering with Black-owned CBOs and practices that serve inclusive referrals to sexual health services?
That's a great question. So my experience and what I did is I found the funding. And so because I found the funding, I did write the grants and then was able to get the buy-in from the trust that was built from previous years. But my thought is having numbers, data, being able to show the need and then also what services you are providing and outcomes. So I think that those are important.
Thank you. And then Dr. Claudia, what challenges or barriers did you find in conducting your survey with Black parents?
Well, I think the biggest challenge has been finding people who actually want to participate. Um, I think, I tried to do something similar, like when I was talking about the data with the kids who were being seen in the ED. I tried to do a qualitative study amongst youth who have been seen in the emergency department. And honestly, the biggest challenges that I'm finding are finding people who want to participate and recruit or like want to participate in the studies. And I think that's for a lot of different reasons. It's interesting. Someone in one of the interviews told me recently that the reason that things are the way they are, especially here in Seattle, is because there isn't a large community of Black people. And that because Seattle's so expensive, so a lot of even what the small communities have been displaced, have been kind of gentrified out from their homes and their communities. Like there's just such mistrust around big medical centers and medical systems that people, even more so than what I experienced in like living in North Carolina. And it's strange to me because I didn't think that that was an experience that I would have in here in Seattle. But I think one of the things that's been helpful, and one of the things that the person who I was interviewing told me, was that if even partnering with people who are already in the community, me as somewhat of a new transplant, I've only been here 3 years, but partnering with those people who have been a part of the community already and letting them kind of take the lead, and me honestly really just listening, I think has been super helpful in breaking down those barriers. But yeah, I think the biggest part is actually the recruitment.
Thank you for presenting. Um, how do you navigate or support students regarding transportation barriers when accessing care at SBHCs, when it's not directly on campus or community clinics? And that can be, yeah, whoever would like to answer, take that.
Yes, we all know that transportation is a huge barrier. Um, the luxury of Denver metro area is there's buses on every street, so that kind of helps. And also, it's free for youth to just hop on a bus, and that I would just say I'm grateful for that. Um, there's also Uber and Lyft. I'm thinking of innovative ways of how can I apply for funding that pays for that. Some organizations or clinics have taxi services that through grants to help with to alleviate some of the barrier of transportation. But and then how do you make it confidential, right? Where when you leave school to attend an appointment, like those are all of those challenges and barriers. But the luxury again is having those school-based health centers that are there. I think that teens just are afraid to utilize them more because they think that they're being judged by how many times they go into the clinic. And so just thinking of more innovative ways, and I'm open to as well to find out how do we eliminate that barrier of transportation.
Thank you. And I feel like that kind of segues into probably one more question we can get through before we're getting close to closing out. How do we ensure confidentiality with adolescent referrals in areas or states with increased parental rights? You both kind of mentioned it, so I feel like that's a good segue.
Yeah, I think one of the biggest things is to first know what the laws are in your state. And I think, especially now more than ever, while things are constantly evolving and changing, I live in a very progressive state, similar to Denver, which is where I lived before I lived in Seattle, where 12-year-olds can access reproductive health and greater than 14 can access STI services. But knowing that a lot of people don't have those luxuries. So I think the first starts with, for one, not only for providers and community workers to know what those laws are, but also for youth to know what the laws are. Because I guarantee if you ask most youth, they have no idea that they can access these services. And then they also don't know how to access these services. I don't think the issue tends so much to be around the confidentiality part as much as the fact that kids don't know that they can actually even get confidential services to begin with. But then once they're in, I think making sure that the systems, especially the systems that we're referring them to, are set up to provide confidential encounters. So making sure that prescriptions are able to, I don't know if it means providing them within the clinic space. For kids who have Medicaid, they don't get those itemized bills, but for kids who have private insurance, those parents are going to get those itemized bills. And that is one of the ways that we primarily break confidentiality for kids. So I think understanding like what the insurance laws are, understanding what the state and local laws are, and then ensuring that wherever the kids are going, that those protections are set up with regards to prescribing, for ordering tests, and for communication. I know some of the acts that have, like the CARES Act that have come out more recently, have changed what people can see in medical charts. And so it's a lot easier now for parents to be able to access what a provider writes in a clinical note. So making sure that those things are kind of checked, and are set up to actually provide confidentiality, I think are super important.
And just to kind of piggyback, I agree with everything that Dr. Claudia said. And I would also add again, thinking of innovative ways. Maybe it's an Amazon locker that you're sending prescriptions to. Maybe it's partnership with the school-based nurse to be able to provide, treatment or anything like that. But when we're talking about confidentiality, it is hard because I've heard that, parents finding out and then them getting in trouble or kicked out of the house, like all of these scenarios and things that really happen. And so again, knowing the laws, and providers being able to ask parents to leave the room to make sure that in a clinic, or a clinical room. So I think that those things are important, but it is hard to keep confidentiality. And also they're just creating more ways to be confidential. When you're Googling stuff on the internet, you can click something that that hides your screen and pops up with something else if someone came around. So there's all types of things to try to prevent, or to continue to have confidentiality. But with private insurance versus Medicaid, it's totally different. So it's just hard.
Thank you both so much for answering our questions. We still have some more, so if your question was not answered, we will be sending a follow-up and try to get all of those questions answered. We're going to move forward into our poll. So we'll have a brief poll. Please take a moment to complete the evaluation that will appear on your screen. We hope that you were able to take away a lot of points from today's webinar that you can use in your own workplace.
While we wait for that, thank you again to our presenters for joining us today and sharing your expertise. Any last second takeaways while we wait for folks to complete the evaluation poll?
I would just say there's still a lot of work that needs to be done, but partnership and being embedded in the community is important, and having relationships with nonprofits, schools, and other private and public sectors. Um, we can get it done, and we can at least make a stamp and moving forward.
Totally agree. I mean, I think the first step is the fact that you all are even here, and recognizing that there's issues and problems and trying to solve them is huge. And NTSD for creating this referral toolkit that's going to be so helpful to people. And then, I mean, even people like myself and Q, like there's so much work that we can do in so many ways that I know I can be better as a provider, as a researcher, as a community person, and an advocate. And so yeah, I just kind of like I mentioned in the last slide, like not forgetting about these communities that are just so disproportionately affected by poor sexual and reproductive health outcomes.
Thank you so much for your last takeaways. We're coming to a close here. So if you would like to learn more or connect with NTSD's Adolescent Health Team, please email us from this email here. And the slides and additional materials will be sent out to all attendees that were registered for the webinar. We want to thank you all again for joining us. We want to thank our presenters for doing an excellent job. And if there's anything else, I'm going to turn it over to Christy. And I think that I think we're going to be closing it out. We want to just thank you all for joining us today.
Thank you, everyone.
Thank you.